Hello, my name is Georg Schmölzer. I'm a professor at the University of Alberta, and I'm excited to be here today with my esteemed colleague Dr. Yousef, and I would like to thank Monivent for organizing this webinar. My talk will cover chest compression techniques in the delivery room, and I would like to disclose the following. I also will present some results from a currently unpublished trial. The majority of newborn infants make the transition from fetal to neonatal life successfully, without our help. However, 10 to 20% of newborns need respiratory support, which is the most critical step of neonatal resuscitation. The need for chest compression in a delivery room is rare. However, when chest compressions are delivered, it is associated with high incidence of mortality, as well as short-term neurological morbidities, as well as long-term neurological sequelae, including long-term neurodevelopmental disabilities. The poor prognosis associated with receiving chest compression in a delivery room raises the questions as if there are improved chest compression techniques or approaches which are specifically tailored to the newborn that could improve outcomes. The inability to predict which newborn need CPR, and because we're using it so infrequently, has certainly limited our ability to perform rigorous clinical studies on this subject. The current consensus of science and treatment recommendation statement say that you should start chest compression if the heart rate remains less than 60 per minute despite adequate ventilation. Use a 3:1 chest compression to ventilation ratio with 90 compressions and 30 inflations. Use a 2-thumb encircling hand technique over the 2-finger technique. Use a depth of 1/3 of the anterior to posterior diameter, and use 100% oxygen. Over the next 20 minutes or so, I will cover all of these statements with a main focus on the 3:1 compression to ventilation ratio. Now, to actually identify what heart rate level we should use to start chest compression, unfortunately, I can only say that there is no clinical study who has actually examined this in humans. There's also no animal study who has examined different heart rate threshold with longer term outcomes to see if there is an advantage or a disadvantage of starting chest compression or not starting chest compression. There's limited evidence from animal studies that if you have a rhythm and start providing chest compression, it interferes with the cardiac output and changes the blood flow situation within the heart and the blood going or coming from the heart, but otherwise the evidence is rather limited. What is the optimal rate? Well, there is a mathematical model who suggests that the optimal rate depends on the weight and the size of the patient. So in this model, it's stated that a rate of 180 chest compressions per minute might be optimal in a 3-kilo newborn infant. So in our lab, we have used a self-designed chest compression machine, which can provide chest compression to our animal model, and we examined that in more detail. What we found is that yes, the cardiac output, which is nothing else than the sum of stroke volume and rate, is the highest is 180, but it appears that the stroke volume, as well as the end diastolic volume, as well as the left ventricular function, might be optimal at a rate of 150. Now, while we have not examined the rate of 150, we have examined the rate of 180, the rate of 60, as well as 100, 110, and 120. And what we found is that there is actually, in all of these studies, not really a difference in time to return of spontaneous circulation or time to ROSC. Yes, as you can see in this study where we compared 180 to 90, the time with 180 of time of chest compression was much slower, but it was not significantly different. However, it seems maybe higher rate has the potential to improve outcomes. Second thing in the guidelines is the depth of 1/3 or 33% AP diameter, which results in higher ejection fraction, which is based on an MRI and a CT scan of children and newborns, suggesting that this might be the optimal one. Again, in our lab with our chest compression machine, we try to examine this, and what we found is that if you use a chest compression depth of 12.5% of your anterior posterior diameter, you will not get any cardiac output, and none of those picklets achieved ROSC. If you used 25, 33 or 40% depth, all of them received return of spontaneous circulation. Yes, the more depth you have, the higher your cardiac output or your carotid blood flow is. It changes slightly your systolic blood pressure, but it did not affect your diastolic blood pressure. So it might be better to focus on pushing to a threshold or pushing hard, because we have no feedback devices, but the 33% might not be the optimal. It might be in a range between 25 and 40%. Finger and hand position, as you can see from this recent scoping review from Ramachandran, that there is many different positions who have been studied in mannequin, but not in either piglets or in humans. And in one of the studies we compared 4 different finger positions and found that the 2 thumbs as well as the over the head 2 thumbs technique were favorable compared to the other 2 for some of the left ventricular function as well as stroke volume. So we concluded that the 2 thumb or over the head 2 thumb technique should be used compared to the other 2 we examined. For oxygen, there is a total of 7 studies in piglets available. However, none in human and not even an observational study who described if 100% or less oxygen were used. In a meta-analysis of the same studies who provided mortality or time to ROSC, there is no difference in either of them in the piglet model, but the longest survivor was up to 4 hours and none has done a neurological assessment. So that certainly is something where we do not know if 21% might be as good as 100%. In trying to perform a clinical trial comparing 21 with 100% oxygen during chest compression, asking colleagues in neonatology, the majority, and there's like 95% of them I asked, would be happy to compare 50 with 100%, but not 21 with 100% doing chest compression. It certainly then limits the ability for yourself to try to organize a trial if there is certainly not enough equipoise to try both of them. The last thing, and this will be now the remaining 10 to 12 minutes of my talk, will be focusing on the 3:1 compression to ventilation ratio. Now, it is stated that we use the 3:1 compression to ventilation ratio because there's a higher physiological heart rate, so we need to provide more chest compression, but also with a higher breathing rate, so we need more ventilations to get oxygen in, because bradycardia or cardiac arrest is caused by hypoxia and hypercarbia, which is our main cause of cardiac arrest. So if you provide ventilation, that's more beneficial. However, what we don't know is what's the best approach. What's the optimal compression to ventilation ratio? Now, to understand what we need, I think we need to go a few steps back and think about things we might not think at all. Now, if you provide chest compression, there is two theories why the blood is flowing. The cardiac pump theory states that because you push the sternum down and you push the heart against the spine, you squeeze the heart like a sponge and blood is expelled. When you're doing chest recoil, blood flows back into the heart. Now, the other theory is because you do chest compression, with chest compression you get an increase in your interthoracic pressure, and because the interthoracic pressure increases, the blood is flowing. Now, these are the two most common theories of how the blood is flowing. And I think whatever we do, we need to use both of them. But what is often overlooked is a negative effect of chest compression. Now, this is a beautiful study by anesthesiology colleagues from Edmonton, where they went into the theater and had almost newborns all the way up to 18 years old and pushed gentle on the chest to just see how much gas is moving in and out of the chest by pushing onto the chest. Now, the bottom graph is the one I would like you to focus. You can see the dark black line, which is the dead space estimated by 2 milliliters per kilo for each patient. And if you zoom in into the initial year of 0 to 1 year of age, you can see that there are several of these patients where they gently push the chest, and you can see that the volume moved and expelled is over 4 mils per kilo. And that certainly is concerning, because if you only gently push on the chest, you already get that much volume moved. Similar, when we looked at our patients, we used a force of 2 kilos, which is much more than what they were using in this experiment. And you can see at the bottom that between 25% chest compression depth and 40% chest compression depth, the volume moving changes quite dramatically. And this is something I would like to focus in the next few slides in more. Now, this is 3 to 1, which you all know, where you give a inflation and then you give 1 and 2 and 3 chest compression, inflation, 1 and 2 and 3 chest compressions, and then again. So this is classic approach. And now when you analyze the gas flow pattern and how much tidal volume is moved in and out, you can see that the inflation provides a large tidal volume, but then you squeeze the chest, a lot comes out because of your compression. During recoil, if you use 3 to 1 with a PEEP of 5 or 6, a little bit of volume comes back in and then more comes out with the next compression, and then a little bit comes out and a little bit goes back in and a little bit more comes out. And overall, with each of this cycle, there was a difference of 4.5 mils per kilo, which could be lost. So now if you would provide chest compression over a longer period of time, there could be quite some loss in tidal volume over time. That certainly is concerning and might be a reason why when several different studies tried to compare different compression to ventilation ratio, they did not find any difference. An alternative which is often brought up is continuous chest compression with asynchronized ventilation. Now this is a video which you might often see in an emergency room or in a pediatric intensive care unit, where again you provide a ventilation and then you do chest compressions, and these chest compressions are continuous, and after every 6 or 7 chest compressions you will provide another inflation. Again, similar than the one before, you get a good volume in, but then with each chest compression there's more volume losing than you recruit. So again, you get a loss of tidal volume over time, and that might be a reason why your duration of chest compression could be longer. When you compare this to a technique we used and designed in our laboratory, where we combine chest compression, which is given continuously, and provide a high distending pressure, which we called sustained inflation, in short CCSI. With this technique, we, as you can see, were able to improve survival and significantly decrease the time to return of spontaneous circulation. Now, what's the difference? Again, if you look here, you just provide a sustained inflation by occluding the T-piece and provide continuous chest compression. The duration of the sustained inflation is 20 seconds. Then you lift your finger off for 1 second and you put it back on again. And with this, you can see that gas is moving continuously in and out with each chest compression of the lung, thereby basically passively ventilating. And if you analyze it in this cycle of all of this chest compression, you have a gain of 2.3 mils per kilo. So you don't lose volumes, you don't de-recruit the lung, you're actually recruiting the lung to continuously provide open lung and preferable optimal oxygenation. The second part is, and that's another reason for our technique, is that with the continuous chest compression as well as using high distending pressures, we use 2 techniques to increase endothoracic pressure. And in animal studies, when they're compared 3-to-1 with CCAV, so this continuous with asynchronous ventilation, you can see that there's no difference in hemodynamic parameters. However, when you then compare that to CCSI, you can see that 3-to-1 and CCAV were basically both the same, but CCSI is significantly improving your carotid blood flow as well as your pulmonary artery flow. Your pulmonary artery and mean arterial pressures are also higher, but your CVP, because of the fear of impaired venous return, is not an issue. So over a decade or so, we have done many studies and found in all of our studies that it provides faster time to ROSC, lower mortality, it improves your hemodynamic, it improves your minute ventilation and your oxygenation, you achieve passive ventilation, and you have no pneumothoraxes or any problems with lung or brain injury. So, randomized controlled trials in the delirium might be warranted. We did the pilot trial in less than 32 weeks gestation, only recruited 5 in the CCSI group and 4 in the 3-to-1 group. And as you can see here, there was a significant improvement in the time to ROSC, similar than what we saw in the animal model. Yes, there were 2 deaths in the CCSI group, but some of these kids were as small as 24 or 25 weeks gestation. Minute ventilation was significantly improved, and this might be the reason why the time to ROSC was significantly faster. So this then all resulted in the SURVIVE trial, which was completed last year, which was a multi-center trial comparing our technique with 3-to-1. The steering committee and the data safety monitoring committee, you can see here. The primary hypothesis was that in asphyxiated newborns, CCSI compared to 3-to-1 will decrease the time to ROSC. We looked at our data and found that we would need a sample size of 218 infants, because it's a cluster trial with 119 infants in each group, and we would include all newborn infants requiring chest compression in the delivery room and exclude according to these exclusion criteria. It was a cluster randomization to one of the two groups, and each hospital would be with this group for a duration of 12 months, then a 2 months washout period, and then do the other 12 months with the other group. 3-to-1 was just your standard 3-to-1 approach. CCSI, as I described earlier in the video, continuous chest compression at 90, you do your SI for 20 seconds, a second pause, and then another one, pause, another one, pause, was 1 minute, heart rate assessment. If after 5 minutes with CCSI chest compressions are still ongoing, you need to convert to 3-to-1. These are some of the outcomes we were looking into for this trial, and then as you can see, none represents a particular city. They all represent sites who were interested to participate. Unfortunately, the SAIL trial was published as we were starting the study, and as the SAIL trial showed that sustained inflation as an initial respiratory intervention, not doing chest compression, has a higher mortality in infants born between 23 and 26 weeks gestation. There certainly was some concerns for our intervention, so the trial was stopped, discussed between the steering committee and the DSMB, and infants only over 28+0 in term requiring chest compression in the delivery room were now included. As you can see, this led to certainly a drop out of many sites because they were worried about the intervention. So we stopped the trial, restarted in Edmonton. We struggled with ethics boards who did not want to approve the trial and waited for more data. We struggled with contract negotiations because insurance companies didn't want to take the risk on to examine newborns receiving chest compression. We got finally under the way, had 6 sites basically ready, but then COVID came around. We had to pause the trial again. And in the end, we got to 4 sites who were able to participate in the trial. After 5 years of trying to get the study done, we stopped the trial. And as you can see, there were 11 in the CCSI group and 14 in the 3-to-1 group recruited at that time. There were no difference in the demographics, no difference in the delivery room intervention. And the primary outcome, as you can see, was time to ROSC, which was 615 seconds on median with the 3-to-1 and only 90 seconds with CCSI. Because the numbers are so small, it was certainly not significantly different. But as you can see in this database analysis, you can see the time roughly for 3-to-1 is somewhere between 6 to 8 minutes. So with our 10 minutes, 6 to 9 minutes. So with our 10 minutes, we're roughly in between this time frame or this duration. Survival was 82 with CCSI and 42 with 3-to-1. And depending on the database you look at, it's around 60 to 70% potentially in database. There was also no difference in secondary outcome. Mortality as well as pneumothorax and intraventricular hemorrhage were safety outcomes, and there were also no difference compared to using 3-to-1. Where does that leave us now? Well, there is 2 studies now done by us, and in both we have an improvement in time to ROSC, on average up to 2 minutes, given the numbers we have. So this now leads us that we want to do now a larger trial and hopefully get more patients and many more sites. So if there's any interest, please contact me on the email up on the screen. And I would like now to thank all of my members of the team and everyone over the years who involved with working on CCSI. And if you're interested, please email or follow us on Twitter or YouTube, and I'm happy to answer any questions. Thank you.